Hemostasis disorders can be placed into one of three categories: platelet disorders, either quantitative or qualitative; bleeding disorders, either congenital or acquired; and thrombotic disorders, which we'll discuss in next week's lesson. Localized bleeding is usually not associated with hemostasis disorders, but rather secondary to some other condition. Generalized bleeding is most often related with hemostasis defects. Primary hemostasis disorders include blood vessel anomalies, abnormal platelet function, thrombocytopenia, and von Willebrand disease. Secondary hemostasis disorders include either single or multiple coagulation defects. Mucocutaneous hemorrhage occurs in the skin or mucous membranes, whereas anatomical hemorrhage occurs in the soft tissues. Mucocutaneous hemorrhage is usually due to lack of platelets, defective platelets, von Willebrand factor deficiency or defect, or vascular defects, as impairment of primary hemostasis. Anatomical hemorrhage occurs in the soft tissues and is most often due to coagulopathies, deficiencies or defects in coagulation factors, which is associated with impairment of secondary hemostasis. Examples include bleeding after minor surgery and internal bleeding, which can occur in the joints, various body cavities, muscles, or the central nervous system. Acquired coagulopathies are secondary conditions that are often associated with other diseases such as liver disease, kidney disease, cancer, chronic infections, and autoimmune diseases. They can also be related to vitamin deficiencies, such as vitamin K and vitamin C, pregnancy complications, exposure to certain drugs, and trauma. Congenital coagulopathies are typically diagnosed earlier in life and often have a familial history. They often result in repeated bleeding episodes. Acute coagulopathy of trauma shock is triggered by injuries related to inflammation, platelet activation, tissue factor release, hypothermia, acidosis, and hypoperfusion, all parts of systemic shock. Treatment consists of colloid plasma expanders, plasma, massive transfusion, and platelet concentrates. Most procoagulants are produced in the liver. Cirrhosis, hepatitis, obstructive biliary disease, cancer, poisoning, and bilirubin metabolism disorders can impair their production. Vitamin K dependent coagulation factors are mostly affected, which are factors 2, 7, 9, and 10, and the control proteins C, S, and Z. Factor 7, with the shortest lifespan, is the most affected, making it an early marker. So how do we differentiate between deficiencies caused by liver disease versus those caused by dietary vitamin K deficiency? Factor 5. It's not vitamin K dependent, so deficiency of this factor is an indicator of liver disease rather than a dietary problem. Fibrinogen is an acute phase reactant produced in the liver and may be elevated in early hepatic disorders. Moderate to severe liver disease results in production of fibrinogen that is coated with excessive sialic acid, resulting in dysfibrinogenemia, associated with soft tissue bleeding. Von Willebrand factor, factor 8, and factor 13 are also acute phase reactants, but not produced in the liver. Platelets may decrease due to sequestration and destruction in the hepatic portals. In alcoholics, platelet production is decreased, which can result in bleeding or thrombosis. Disseminated intravascular coagulation, or DIC, may occur due to decreased production of antithrombin, protein S, and protein C by the liver. In DIC, the protime, PTT, thrombin time, and D dimers are all prolonged and fibrinogen is decreased. Chronic renal failure results in decreased RBC and platelet production in the bone marrow, as well as platelet dysfunction due to coating by substances in the kidneys. With nephrotic syndrome, which results in increased glomerular permeability, procoagulants and control proteins are lost in the urine. Vitamin K is abundant in green leafy vegetables. Vitamin K deficiency is usually not a problem for most people. Deficiencies of this type are most likely seen in patients who are receiving high quantities of IV solutions, engaged in severe diets, or who are not able to absorb vitamin K. Vitamin K is produced by intestinal bacteria and is fat-soluble, requiring bile to be absorbed. Therefore, biliary obstruction can lead to deficiencies, as well as fat malabsorption and steatorrhea. Antibiotic treatment may also lead to vitamin K deficiency due to intestinal flora depletion. Vitamin K may be administered to newborns who lack intestinal flora to avoid hemorrhagic disease of the newborn. Coumadin is a vitamin K antagonist. In order for factors 2, 7, 9, and 10 to be functional, they require an extra carboxyl group, which later will bind to calcium in the coagulation cascade. Carboxylation is aided by vitamin K. This reaction is inhibited by coumadin-type oral anticoagulants. Therefore, the liver releases inactive forms of the coagulation factors and regulatory proteins. Bleeding may occur due to coumadin overdose or poisoning, such as rat poisoning. In severe cases, patients may receive intravenous vitamin K, whereas in moderate cases, oral vitamin K is administered, which takes at least 3 hours to effect. Acquired hemophilia is antibody-mediated. Antibodies to factors 2, 5, 8, 9, 10, 13, and von Willebrand factor may cause acquired hemophilia, but anti-factor 8 is the most common. Acquired hemophilia is usually associated with an autoimmune disease such as rheumatoid arthritis and lupus, and pregnancy, about 5 months after delivery. Patients will have normal protimes and thrombin times, but abnormal PTTs that will correct with mixing studies and confirmed with factor assays. Treatment consists of immunosuppressants. Acquired von Willebrand disease can result in either decreased production of von Willebrand factor, production of an autoantibody, or abnormal function, such as absorption to cell surfaces. It occurs in patients with hypothyroidism, autoimmune diseases, monoclonal gammopathies, certain tumors, coronary heart disease, pesticide poisoning, and hemolytic uremic syndrome. Patients have a prolonged PTT, but not protime. It can be difficult to distinguish between acquired and congenital von Willebrand disease at an early age. Acquired von Willebrand disease is treated with plasma-derived factor VIII von Willebrand factor concentrate. It is no longer treated with cryoprecipitate. Although DIC is a thrombotic condition, it may lead to bleeding. DIC will be discussed later in the thrombotic disorders. Congenital von Willebrand disease is a hereditary condition that affects primary hemostasis, or platelet adhesion, and thus patients will exhibit abnormally prolonged bleeding times. There are three types of von Willebrand disease: type 1, type 2, and type 3. Hemophilia affects about 1 in 5,000 male births in the U.S. annually. That equates to about 400 babies every year. About 85% of hemophilia cases are hemophilia A, which is caused by a deficiency of factor VIIIC, not factor VIII von Willebrand factor. Factor VIII is, of course, antihemophilic factor. About 14% of hemophilia cases are hemophilia B, which is a deficiency of factor IX, plasma thromboplastin component, or Christmas factor. And around 1% of hemophilia cases are hemophilia C, a deficiency of factor XI, plasma thromboplastin antecedent. For the remainder of this lesson, we are going to study von Willebrand disease and the hemophilias. Other congenital deficiencies are not going to be covered in depth, as they are rare and caused by autosomal recessive mutations associated with consanguinity, or having common ancestry. Of these, the ones that lead to severe anatomic bleeding are fibrinogen, factor VII, and factor X. Factor XIII results in moderate to severe systemic bleeding and poor wound healing. Factor II and V lead to mild systemic bleeding. Von Willebrand disease is an autosomal dominant inherited condition resulting in abnormal mucocutaneous bleeding. It is considered the most common congenital bleeding disorder. Von Willebrand factor is a glycosylated protein composed of 2,813 amino acids. It forms dimers, which are transferred to storage locations in platelets, the alpha granules, and epithelial cells, Weibel pallade bodies. In storage, the dimers polymerize to form very large polymers. When released in response to hemostatic stimuli, a cleaving protease, ADAMS13, cleaves the stored large polymer into smaller multimers of different sizes. TTP, or thrombotic thrombocytopenic purpura, is caused by a deficiency of ADAMS13, resulting in the release of extra-large polymers instead. Von Willebrand disease patients usually have a normal protime and PTT, except for type 3, which has an abnormally prolonged PTT. A von Willebrand factor monomer has 4 functional domains: one that binds factor VIII, one that binds to collagen, one that binds to platelets GPB or GP1b9-5 complex. The GP1b on platelets bind to von Willebrand factor, and then platelets become activated and express the GP2b3a that binds to von Willebrand factor. And finally, one that binds to platelets GP2B3A complex. The von Willebrand factor antigen epitope is the target of immunoassays. The binding of von Willebrand factor with factor VIII is protective for factor VIII. It prolongs the factor VIII plasma half-life from a few minutes to up to 12 hours. Von Willebrand factor plays a central role in primary hemostasis, where it mediates platelet adhesion to damaged vascular subendothelium and subsequently platelet aggregation. Following a vascular injury, von Willebrand factor binds to collagen, both types 1 and 3. Two distinct platelet receptors for von Willebrand factor, the glycoprotein GP1B in the GP1B9,5 complex and the GP2B3A complex, are present on the platelet membrane. Von Willebrand factor dependent platelet adhesion occurs best under conditions of high fluid shear stress, such as rapid blood flow. The interaction and binding of the platelet GP1B receptor with the A1 domain of von Willebrand factor results in platelet adhesion. The process ultimately leads to stable platelet adhesion by means of interaction of the platelet collagen receptors GP6 and GP1A 2A38, activation of the platelet GP2B3A complex, and finally, platelet aggregation. Factor VIII is a combination of two subunits, factor VIIIC and factor VIII von Willebrand factor, that circulate as a complex known as factor VIII von Willebrand factor. Subunit 8C deficiency corresponds to classic hemophilia A. There are three types of von Willebrand disease. The most common is type 1, which is a quantitative defect caused by a mutation on the chromosome 12 von Willebrand factor gene. 75% of von Willebrand disease patients have this type. There is a proportional decrease of multimers of all sizes. Type 1 leads to bleeding after minor surgery and menorrhagia in women. Von Willebrand factor antigen and von Willebrand factor RCO, which is activity, are both decreased. Type 2 is a qualitative abnormality leading to a decreased function of von Willebrand factor. Subtype 2A accounts for around 10% of all cases. Von Willebrand factor is more prone to proteolysis by ADAMTS13, which results in more of the smaller-sized multimers being released, which are not as effective at capturing platelets. Patients exhibit a normal or slightly decreased von Willebrand factor antigen assay, but decreased von Willebrand factor activity because it is the large monomers that are more efficient at binding platelets. Subtype 2B is a mutation that results in increased affinity of the multimer for platelet GP1B. This leads to arrest of resting platelets, which become adhesive to the epithelium and become unavailable for adhesion when injuries occur. It may also lead to thrombocytopenia because multimer-covered platelets bind to the endothelium. The electrophoretic pattern shows only intermediate and small weight multimers, but no high molecular weight ones. Patients exhibit normal or slightly decreased von Willebrand factor antigen assays, but decreased von Willebrand factor activity. Pseudo von Willebrand disease, or platelet type von Willebrand disease, is similar, but the problem is in the platelet, not the von Willebrand factor. These platelets have an increased affinity for von Willebrand factor. Subtype 2M is von Willebrand factor with decreased platelet binding receptors, but normal multimeric electrophoretic patterns. It is diagnosed by the discrepancy between the von Willebrand factor antigen assay and von Willebrand factor activity, which shows normal levels but low activity. Subtype 2N is the Normandy variant, a rare autosomal mutation that impairs von Willebrand factor binding to factor VIII. This leads to factor VIII deficiency despite normal von Willebrand factor antigen levels and activity. It is also known as autosomal hemophilia because clinically it is indistinguishable from congenital hemophilia, but it affects both males and females. These patients do not respond to factor VIII concentrates. Confirmation is made with molecular tests that detect the mutation. Type 3 is an autosomal recessive mutation. Von Willebrand factor is absent or nearly absent from plasma, while factor VIII is proportionally decreased or absent. Both primary and secondary hemostasis are affected. Patients exhibit a marked decrease von Willebrand factor antigen assay and von Willebrand factor activity. The von Willebrand factor antigen assay is an immunoassay that uses a reagent containing labeled antibodies to the von Willebrand factor antigen epitope. It gives an indication of the level of von Willebrand factor present. The von Willebrand factor RCO assay uses a reagent containing preserved platelets and ristocetin, which supports agglutination of platelets in the presence of von Willebrand factor. It measures the ability of von Willebrand factor to bind to platelets and therefore gives a measurement of von Willebrand factor activity. The activity to level ratio is normally greater than 0.5. RIPA, or low-dose ristocetin-induced platelet aggregometry, or ristocetin response curve, uses platelet-rich plasma and only a very low dose of ristocetin is added. A normal patient needs more than 0.5 milligrams per milliliter of ristocetin to show platelet aggregation, whereas von Willebrand disease patients, type 2B, will show platelet aggregation because platelets are already coated with large multimers in vivo. When the reagent is added, even if it is a very small amount of ristocetin, less than 0.5 milligrams per mil, aggregation will occur. The PTT measures all factors except 7 and 13, so it is the test that measures factor VIII. The PTT may be prolonged due to a problem with factor VIII or in the carrier molecule von Willebrand factor. Factor VIII activity is a factor VIII specific clot-based assay. The PTT is determined using factor-depleted platelet-poor plasma. For example, factor VIII depleted platelet-poor plasma for the factor VIII assay. Two samples are tested. Sample A is mixed 1-to-1 with normal plasma with factor depleted platelet-poor plasma. For sample B, we mix 1-to-1 patient platelet-poor plasma with factor depleted platelet-poor plasma. The clotting time is determined, followed by determination of factor activity by using a calibration curve that has time in the y-axis, which is a linear scale, versus percent factor activity in the x-axis, which is the logarithmic scale. The reference range for factor VIII is 50 to 150% activity. Normal hemostasis requires at least a quarter or 25% of factor VIII activity. Table showing the expected results of coagulation tests for each type of von Willebrand disease. Hemophilia A, or classic hemophilia, accounts for about 85% of all hemophilias and is caused by a factor VIII deficiency. Thrombin cleaves factor VIII, and what is left is a molecule that detaches from von Willebrand factor carrier and binds to phospholipid and factor IXA in the presence of calcium. The factor VIIIa 9A or tenase complex cleaves factor X at a rate 10,000 times faster than thrombin. Factor VIII is a big helper for thrombin. Its deficiency slows down the cascade process to such a degree that results in bleeding. The factor VIII gene is on the X chromosome, which is why mainly men experience the disease. Severe cases are usually diagnosed in newborns, but newborns usually have a prolonged protime and PTT anyway due to low levels of vitamin K dependent factors, which include 2, 7, 9, and 10. But factor VIII levels are usually similar to those found in adults. So the best course of action is to perform a factor VIII activity assay to detect hemophilia in newborns. Treatment for hemophilia A is transfusion of recombinant factor VIII concentrate. About 30% of patients with severe hemophilia A will develop inhibitors to transfused factor VIII. Factor VIII is a combination of two subunits, 8C and 8 von Willebrand factor, that circulate as a complex known as factor VIII von Willebrand factor. Subunit 8C deficiency corresponds to classic hemophilia A. Around 10 to 15% of hemophilia A patients develop an alloantibody to factor VIII in response to treatment. It is not an autoantibody because they don't have factor VIII. The presence of an inhibitor is suspected when the patient starts to bleed regardless of receiving treatment. A Bethesda unit is a measure of inhibitory activity. The amount of inhibitor that will inactivate 50% or 0.5 unit of a coagulation factor during the incubation period. It is therefore used for measuring coagulation factor VIII inhibitory activity in plasma. 1 Bethesda unit reduces factor VIII in 1 ml of plasma from 1 to 0.5 units. As previously mentioned, treatment for hemophilia A is transfusion of recombinant factor VIII concentrate. And in 10 to 15% of hemophilia A patients, they are expected to develop antibodies to transfused factor VIII. The presence of an inhibitor is suspected when the patient starts to bleed regardless of receiving appropriate factor concentrate treatment. Mixing studies will help detect the presence of inhibitors, proven by decreased factor VIII activity assays, which will be less than 30%. Mixing studies will help determine if there are inhibitors. Patient plasma is mixed with normal plasma and then incubated at 37 degrees for 2 hours, followed by rerunning the PTT. If inhibitors are present, the PTT will not correct because the inhibitor will neutralize the factor VIII from the normal plasma. If the mixture comes within 10% of the incubated normal plasma, inhibitors are not present. If an inhibitor is suspected, then the Bethesda assay is performed to quantitate the inhibitor. In a series of test tubes, prepare increasing dilutions of normal plasma that contain 100% of factor VIII activity with patient plasma. Factor VIII assay is performed on each tube. The results are reported in Bethesda units. 1 Bethesda unit equals the reciprocal of the dilution that caused neutralization of 50% of the normal plasma activity. Around 14% of all hemophilias are hemophilia B, otherwise known as Christmas disease. It is caused by a heterogeneous group of sex-linked mutations that result in a deficiency of factor IX. Factor IX is vitamin K dependent and serves as the substrate for factor XIa and factor VIIa. It is cleaved by either to form factor X, which is then activated to factor Xa and activates prothrombin to thrombin. A deficiency of factor IX leads to reduced production of thrombin and soft tissue bleeding. Treatment consists of recombinant plasma-derived factor IX. Inhibitors will appear in about 3% of patients. As previously mentioned, around 3% of patients who receive recombinant factor IX concentrate will develop anti-factor IX antibodies or inhibitors. A factor IX activity assay is performed, which should show low activity for factor IX, but normal activity for factors VIII and XI. Mixing studies will help detect the presence of inhibitors. Equal portions of patient plasma and normal plasma are mixed and incubated for 2 hours at 37 degrees, followed by repeating the PTT. If the PTT corrects, then no inhibitor is present. If the PTT does not correct, then a factor IX inhibitor is likely present, in which case the Bethesda assay is performed to quantitate the inhibitor. Hemophilia C, or Rosenthal syndrome, is a deficiency of factor XI that results in soft tissue bleeding. It causes about 1% of all hemophilias. Around 1/2 of all cases of hemophilia C are found in the Ashkenazi Jewish population. Treatment consists of plasma transfusions when needed. Factor XI activity assay will show low activity for factor XI, but normal for factor VIII and factor IX.